Welcome and thank you for joining Don't Let Your Anesthetic Be a Pain. My name is Dr. Lori Trost and I will be providing this program about common sense approaches to selecting and administering dental anesthetics easily, successfully, and without discomfort. Just a little about me. I practice restorative dentistry in the greater St. Louis, Missouri area. Above all, I really do profess to be a lifelong learner and love dentistry for a long time. It's just a wonderful profession. I'd like to take the opportunity to thank those responsible for this program, Septidont and the Viva Learning platform. I would also like to disclose that although I have no personal financial interest in any of these products, I am receiving an honorarium for this program. All the products and procedures used in this program are supported in the literature as well as used in my practice. Just a few housekeeping points before we start. This is a continuing education program. To receive credits, follow the cue at the end of the webinar and proceed on to the CE questions. Also, feel free to submit any kind of questions you have during the program. Just type them in the question box, and for continuity purposes, I'll wait to answer those at the end of the program. With that said, I really do consider this a privilege to share time with you, so let's get started. I once heard someone say at a continuing education seminar that at the end of the day, patients pay attention only to a few things. How do they really judge their dentist? You know, did it hurt? Does it look good? And if they were treated nice. There's certainly some truth to all those things. But patients don't understand if your margins are impeccable or if you put them in the most stable occlusal scheme possible, or even if you make them jump, but when an injection is given, they're going to remember that. They know if it hurts. A painless injection, though, certainly ranks first and foremost in their minds, and we've got to really work hard as clinicians to make sure that we are building trust and, more importantly, administering painless injections. In a 1994 Quintessence International article, the author asked over 3,000 practicing dentists about their personal stress when they administered local anesthetics to their patients. More than 24% of respondents indicated that the administration of local anesthetics is a significant cause of professional stress. So we're admitting that, and it is stressful. It can be stressful obviously for patients. It's very stressful for us as well. You know, think about when the failures happen and how much more stress that loads on us. So this program really hopefully will help answer and help you discover really how to determine the right drug for the right patient and the right procedure. But just selecting the right drug for the right clinical situation does not always ensure a good outcome. There are failures. We're going to talk about those factors involved when you don't achieve profound anesthesia. We're going to learn how to talk about matching the anesthesia to the anticipated length of the procedure. We'll discuss also strategies for those hard to numb patients. And if, you know, the question is, do you always need a vasoconstrictor? And finally, giving a painless injection and techniques in order to do that. So we're going to kind of go with that and just kind of move off of the experience that we've had and how we've learned and over time and just share that knowledge, and that's all good stuff, good clinical meat and potatoes here. So what are the top reasons patients are reluctant? They're reluctant for a lot of reasons, and in ascending order here, smells and sounds. Obviously we knew the drill was in there somewhere, but you know, when you get down to the needle, studies confirm that 82% of patients have some form of anxiety when they come to the dentist. And it really stems a lot from the needle. I can't tell you how many times I've had patients say, are you going to shoot me? No, I'm going to give you an injection. No, I'm going to get you nice and numb. Those are usually the responses that follow. So this is first and foremost in their minds. And we've got to remember as clinicians, this is really about an experience for them. It's just not treatment. We really need to explore ways that we can reduce the anxiety because it is real. It certainly snowballs for many patients, and a lot of times you see patients get so wound up before they even get started, so they don't ever give you a chance. So again, we're going to talk about a lot of strategies and really what is some of the science behind this. So dental pain perception is reality. It's a cognitive as well as an emotional feature in our bodies. To get to the brain, pain, the signal travels through the spinal cord through a dense array of nerve cells known as the dorsal horn. We've learned about that in physiology and neurology, where the gate control action takes place, and it either conveys or inhibits the pain signals. Pain signals are carried by two types of nerve fibers. And interestingly enough, pain is more likely to be reported by those who had a previous painful experience and they're anxious about the dental treatment. It's also more likely to be reported by younger patients and also those patients with higher educational levels. So it's important to remember that this is a broad-reaching issue about not only the anxiety, but how the physiology of pain and how it relates emotionally and cognitively throughout our patient pool. And here you can see the physiological effects that many patients experience. These are very visible. I mean, obviously shaking can be one thing, but often you'll see patients, they need to go to the restroom often. They get quiet. Sometimes they don't hear you as well. But again, these are all signs that we need to pay attention to when we're treating those patients. And again, remember, this is this pain factor can be associated, that anxiety kicks it up, the emotions kick it up, so there's a lot of things that are playing off of each other, and they certainly can tandem. So we need to make this, again, about a very good experience and simplify it and get our messaging correct and really learn some common techniques. And we'll go into that in just a little bit further into the program here. So what are the breakdown of current anesthetics on the market today? Really, local anesthetics are acid salts of weak bases. They are either an amide or an ester type, and they differ by their intermediate chain, which is responsible for how they are metabolized and eliminated within the body. Regardless of their chemistry, local anesthetics need to be lipophilic. That allows their flow into and across the neural membrane so that they become effective. You can see here how we have amides. They have rare allergic reactions. They're very safe anesthetic agents, and they're pretty well metabolized within the liver. Esters, on the other hand, have a very low allergic reaction. They're metabolized in the plasma in the body, and they also have the ability that they can cause and precipitate a methylmaglenemia, rather. And we got to be careful about that. When you have patients that come in, for example, that perhaps have some kind of liver compromising disease or perhaps cirrhosis, you should really think twice about providing an amide type based anesthetic. So that's a flag right there. So pay attention to those issues. Esters have a low reported allergic reaction. Again, they're metabolized in the plasma, like we talked about here. And what you got to really pay attention to is they can affect that altered hemoglobin. And what can eventually happen is it has the reduced ability of having red blood cells be released in the oxygen into the tissues, and actually the hypoxia type situation can occur. So that's why you got to be careful about with that. But again, pay attention with patients maybe who have some liver compromising type situations or diseases, and you're going to be careful. Don't be using an amide. That's not going to be an appropriate choice right there. Okay. The types of local anesthetics you can see here, they're chemical formulations here, and again, esters, you'll see procaine, tetracaine, and benzocaine underneath the ester levels, and under the amide listings, you're going to have lidocaine, articaine, bupivacaine, and prilocaine that we're going to really talk about in this program right now here, okay? So essentially just kind of distilling down what we have in choices, okay? First of all, lidocaine has been marketed since 1948. It's been around for a long time. It's been a gold standard for as long as I've been a dentist, you know. And again, as things evolve, we can evolve with them. So that's a good thing. But it has been compared to many local anesthetics. In comparison, I want to note that you also need a vasoconstrictor really to achieve pulpal anesthesia when you are using lidocaine. It is a vasodilator in many capacities. So again, you have to partner that with a vasoconstrictor in order to get that to work more effectively. Another good choice out in the market today is articaine. It has the fastest onset. As you can see here, again listed, it's been available in Europe since 1976, but it really hasn't moved over to the United States until around 2000. This product here is, the standalone anesthetic, is really growing popularity. Why is in the United States? And it's really driven, the success rate is really driven to how it can diffuse faster into the heart and soft tissues and achieve pulpal anesthesia. And that's really the reason that it has a sulfite group that is responsible for making it a more lipid soluble type product, and it can boost its effectiveness. So again, it has a good potency. It's the least toxic of all the amides, and it has good metabolism. It's safe, And the beauty of articaine that I've found to be very successful in my practice is you're able to re-inject in 30 minutes. And we'll talk a little bit more about that as well, too. I do want to also point out, too, a couple of things. If you have any patients who are hypersensitive to or have perhaps a bisulfite allergy, you don't want to be using any kind of articaine type products with them, again, because it will be a contraindicated type of reaction there. So that's just a heads up on that one as well. And each of these have their pros and cons as we're going to move through this list. Prilocaine has been around since 1965. It's less toxic and less potent than lidocaine or bupivacaine, and it also has a slightly longer duration of action. An interesting feature regarding prilocaine plain is that not only does it have a milder vasodilator effect than the amides, but when you're providing a block, there's only an intermediate type duration of the anesthetic. So pay attention to those kind of things. So a patient perhaps who has a contraindication for a vasoconstrictor, this is a great choice to use for their anesthetic. Both formulations of 4% prilocaine are recommended for patients with the epinephrine sensitivity and patients who require immediate action of anesthesia. So this is a very good choice for that. Prilocaine does reduce the blood's oxygen carrying capacity in higher doses, and therefore it is relatively contraindicated, again, for patients who run the risk of oxygenation, such as sickle cell anemia, cardiac or respiratory failure, also methemoglobinemia, as well as patients who are receiving kind of acetaminophen because of those increased methemoglobin levels. Okay, so again, be careful of that. And also, if this is married again with a vasoconstrictor, you got to be careful with the bisulfite allergy, because anytime a vasoconstrictor is married and put into these formulations with these anesthetics, a bisulfite allergy is a contraindication. The last one I'll talk about is bupivacaine here. It's 3%. It has a marginal vasodilation. It's been around and marketed since about 1960. It's available usually in a 2% or even a 3% plain type formulation. It has, like I said, a milder vasodilating type effect than the other amides, and it has a shorter duration, and that's the key here that you need to really take away. The one big caveat, though, with bupivacaine, it's the least acidic, and so it has less pain when there's an injection given. And this is a real win-win, and I'm going to show you a couple of techniques that I've used and learned to use over the years that really play out very well, because bupivacaine is a great tool to have in your kit. We'll talk about that here in just a bit. So really selecting the right anesthetic, there's a lot of choices out there, and I know we base things on our professional judgment, perhaps what a colleague says, but you know, you look at what the patient profile is, and you've got to consider a lot of different takeaways. We need to make sure that the proper duration is going to be there, and marry that for the procedure, and whether you need soft tissue or hard tissue, or perhaps you need pulpal anesthesia. So again, all of these factors are what play into when we're choosing what type of anesthetic we need. We need something that can be predictable and when it becomes numb, and also when it wears off, and the offset as well. It needs to be safe, of course, and it also needs to be cost effective as well. So let's talk about some of those factors that play into decision-making processes here. The first factor I want to talk about is pKa. This is central to how local anesthetics work. The first is pKa, which is really about the onset, and always think about the pKa values that relate and refer to the onset of the anesthetic. How quickly will they start to onset? How quickly will they act? How quickly will that local anesthetic cross the neural sheath and get to that closest to that physiological pH and have a proper ability to work and work effectively? So when you look at comparisons of pKa, these values, again, we want to have something that's somewhat closer to the physiological pH value. And you can see here in this list that two really come close here. You've got bupivacaine at 7.6, and you've also got 7.8 as well with articaine, and lidocaine at 7.9. Now, the next thing you really need to think about is, and I'm going to kick these out here and show you right in here, 7.8, 7.6, 7.9. But look here over to their values. If you look at the onset, articaine has a 1 to 2 minute onset. And that's a very quick onset to work with within your practice. And that's one of the factors I like articaine. Next, following up there, you got the mepivacaine, but again, it's not as long a duration. So you've got some trade-offs here in each of these, okay? Next, I want to talk about another factor, protein binding. This is really what you consider how long the anesthetic will work, the duration. Local anesthetic molecule needs to fit with a receptor in order to open up the sodium channels. So effectively, if the local anesthetic molecule has an affinity for protein, it's going to bind, and that binding process is really crucial for the length of time how the anesthetic will work. So if it's binding, that's a good thing. So the more affinity for the protein, the longer the anesthetic duration. Now, in comparing these different, again, the 5 that we talked about earlier briefly here, you can see here the different values, and again, what's their duration of action. So if you need something that's going to be a longer, obviously a longer procedure, you're going to need a longer duration of activity. So if you go down to articaine, for example, you have 180 to 240 minutes there. Again, you're comparing. Procaine is going to be shorter, lidocaine is going to be a little bit shorter as well. But again, look at onset and look at duration. Again, what your type of procedure you're doing, you need to think about that and factor in what type of anesthetic. How long do I need pulpal anesthesia? How long? If, obviously, an endodontic procedure is going to be totally different than what, say, a simple class 1 occlusal on a premolar, upper premolar. So again, you're going to rank different anesthetics and values and qualities and factors according to what the different procedures are for the patient. Next, we look at a vasodilator activity factor, and this is really important because what happens is vasodilation refers to the duration or time that that local anesthetic is remaining at the neural sheath and performs its duties. Vasodilation is also in direct correlation to the potency of an anesthetic. So obviously a stronger formulation will be more potent and its effect will have more possible vasodilation. Then that's going to reduce the desired anesthetic effect. So how this plays out often is sometimes if you have a product that has a greater vasodilating quality, you can re-inject, and what happens is you're actually the anesthetic is really leaving. The vasodilation is happening so that it's being taken away from where you want the target. So it really doesn't help to re-inject because you're really not helping the situation, in other words. So again, pay attention to which factors and vasodilation on these different products again have, they're just not going to help you. So again, you want a lower value. So prilocaine here and articaine really kind of win in these different categories right here. Liposolubility is another factor here, and obviously the greater the liposolubility factor, the better the nerve cell penetration, and more importantly, the less volume of anesthetic that you're going to be required. So what happens here is all these cell membranes are made of phospholipids, and every molecule has the capacity to go through the lipid membrane. And what happens often is you want to have molecules that have a better ability to penetrate that nerve cell. So obviously the greater liposolubility, the better the penetration into the nerve cell, and the greater the potency and the less volume required, and also that also equals faster effectiveness too. So in a comparison value of this, articaine is actually 4 times more liposoluble than what is lidocaine. So again, it wins on that capacity as well. So again, a very good choice. The final factor I want to talk about is half-life, and this is a really critical factor because it helps you understand how the medications, the anesthesias, are eliminated in the body, whether it's the liver or the kidneys. More importantly, another issue you think about is when can you re-inject, and this is about relationships to the half-life. So really once the anesthesia is over with, the local anesthetic molecule has to be processed by the body, liver or kidneys, and sometimes it can be in the plasma there. The degradation process is measured in the half-life, and it's directly related to the systemic effects here. So you really want to see local anesthetic agents that possess a shorter half-life here. So in the comparison graph I've got here, you can see how articaine has a 20 to 30 minute half-life compared to lidocaine, compared to prilocaine, compared to mepivacaine. It really wins in those categories. And you can see the decrease at 4.4 hours, almost 4.5 hours, you've got a 98.5% decrease. So it's really a safer eliminating factor than what lidocaine would be, or prilocaine for that effective measurement and comparison. The key takeaway really here, though, like I talked about, is how quickly the toxicity is reduced. So therefore, knowing that half-life gives you really an important factor in how you can and when you can safely re-inject. And again, like I mentioned earlier, articaine you're allowed to re-inject really within 30 minutes. And that's a big win-win on procedures, no matter what kind of procedures you're doing across the board there. Other variables that you consider when you're looking at the effectiveness of local anesthetics are diseased tissue, inflamed tissue, and again, that alters the pH of the tissue and the surrounding areas, so how you're going to be able to get that anesthetic to work for that specific area. You also look for any other kind of competing drug interactions. And this is interesting too, because patients are doing all types of medications now, over-the-counter things, street drugs, and we're competing against sometimes when they tell us, when they don't tell us. So you really got to source out their medical history, and we'll briefly discuss that in a bit, but you got to really be careful. Things can even change too if they're in their tissues. For example, if they're doing smokeless tobaccos, I know that I have patients that will have these patches that come in. You can see exactly where they've been doing this at, and that tissue's altered, and especially, and we'll talk a little bit about smoking too, but again, other drug interactions and other types of, I should say, over-the-counter consumption things, you really got to pay attention to what is out there, because question them really, and learn have your assistants, even your hygienists, really be observant and really look at what their behaviors are, because that might interfere again with the onset and the duration of what you're trying to achieve as well. And finally, you got to think about the nerve anatomy. We have patients that have cross interventions, especially in the midline regions. You have to think about bifid mandibular canals in the premolar region especially. I know that's very common. Think about the path of the mylohyoid nerve. So go back, review a little bit of your anatomy just to see. Sometimes you might have a case that falls into one of these categories. And again, it's not your technique, it's just how the patient is and how they present. I do want to mention another anesthetic it's a reversing anesthetic actually, that I found to be a terrific practice builder. This is the only available agent on the market today, but I mean, how many times have patients said to you they hate going to the dentist because they don't want to be numb for hours after they receive a routine restorative procedure, only to schedule the appointment, and they say, hey, I don't want to be numb. They try to schedule around you, and you try to schedule around them, and it doesn't work. Well, hey, guess what? We all face these types of issues in practices where patients are pushing on you, and they want to be able to be as normal as possible. They don't want to have the ability to bite their lip, or they want to be able to speak properly or smile, etc. So the first agent out there that does reduce anesthetic is Oraverse, and I found this to be an incredible product here. It really helps to simplify time, and it helps to reduce really unnecessary trauma. Oraverse is really phentolamine mesylate. It's essentially a vasodilator, and its use allows patients really to return to a normal feeling within about 30 to 60 minutes versus a 3 to 5 hour situation. So it's a pretty amazing product here. It counteracts the impact of what a vasoconstrictor does in a traditional dental anesthetic, and it allows for a more efficient reversal of the soft tissue anesthesia while having no impact on the pulp anesthesia. So I found Oraverse to be a really value-driven product, and it improves the experience of my patients, and it has led to definitely referrals in our practice. It is a practice builder. There was a study published here in JADA, and the clinical trials, they found that the median time to recover to normal sensation for the upper lip was reduced by 45 minutes, and for the mandibular lip it was 60 minutes. So this is pretty amazing product here. It's interesting enough, 80% of patients are really interested in receiving a product like Oraverse, and I found this to be, like I said, a very good practice builder within our office. We have 2 days a week Tuesdays and Fridays we start at 7 a.m. in the morning, and I can tell you by the time the patients are driving to work, they want those early morning appointments, and they're off and running, they are pretty well back to normal, and they really appreciate that service and how you can offer that to them. So you can promote that in your website, your newsletters. I think it's an amazing, just again, a good practice builder. If you're not doing it, somebody else down the road probably is, and they're going to win over patients. So this is a great adjunct to have. I certainly don't use it on every patient, but we certainly offer it to patients who we think were very capable of taking the benefit of it. Orverse is safely dosed as a 1-to-1 cartridge ratio and has no contraindications. So it's safe, and you can see how the recommended doses: 2 cartridges for adults, 1 cartridge, etc. for patients 6 to 11. Again, a 4th cartridge for kids weighing to 22 pounds. So again, it's safe. What you want to do is you want to look towards the end of the procedure, and traditionally when I know that the procedure is winding down, where say for example I'm doing a couple of composites, for example, I'm going to go ahead and when I get to the point of where the composite's been placed and we've pretty well got the occlusion adjusted, I'm going to go ahead and finish. At that point in time, before I'm going to finish, I'm going to go ahead and re-inject the 1-to-1 cartridge that I'm going to do ratio-wise. And by that time, the finishing and polishing already starts to finish up. By the time the patient's out and being taken out, where they're all take care of their bill, etc., guess what? Their exit, they're going to be starting to have that anesthesia wear off, and it's just a really good timing factor. On crowns, once we get to the point after we've done the impression, we're going to go ahead and inject at that point in time, and so therefore if we're doing the temporaries or we're doing the scanning or getting close to that point in time, that anesthesia again is wearing off. And so we've learned how to time that pretty nicely, and again, it works extremely well. I also like the factor that these cartridges have a blue cap on them there, and you can easily identify them, and it helps to lessen any kind of confusion that you think you might put the wrong kind of cartridge in. You can use the same needle and the same syringe, you just have to load the cartridge in there. So it's a really, I think, great adjunct for your practice. Let's talk about some clinical situations that we experience every day, and some strategies really to solve these and hit these head on. Observing the patient's behavior in the waiting room really is something that needs to start from the person who first greets them, to the person who brings them back and seats them, to the person that treats them. So look for these indicators of dental anxiety. They fidget, they sit on the edge of the chair, they might be flicking through magazines or newspapers. They might change positions, they cross or uncross their legs quickly. It's pretty amazing how they do that too. They're sighing, obviously sweating, you don't want to see them sweat, but again, these are totally behaviors that indicate some type or some level of dental anxiety. You also want to talk about and look for patients who sometimes are very loud in the reception area. You really need to get them seated into an operatory and really try to get them to calm down too. So patients have they have all different ways of how their anxiety really starts to expose itself. Something that we've done in our practice for quite some time, and I think this really is an amazing really kickoff, but we call it the 6 seconds of human touch, and this can really have a massive impact on how you basically greet your patients. But we all greet our patients and we shake their hands for 6 seconds, because we think that this really helps to instill values and trust within the patients. And it's interesting because the human interaction and emotion can really be broken down to a simple chain of those little reactions in your brain, and at the 6-second mark of that handshake, the human brain starts to release enhanced levels of serotonin, and that's really responsible for happiness and elation. It also releases oxytocin, which is strong for bonding, so it helps to really promote more bonding and boosting the mood of your patient. So I think this physical connection really forces that patient's body to feel better, and I think the longer the handshake or even that hug, it helps to create a higher level of chemical release, and it really helps to get into the space of the patient kindly, and I think they see that as a genuine extension and a bridge of trust that kicks off, especially for new patients. I think that's really critical. Before you start treatment, you really need to make sure that the patient is taken care of with a set the stage type of attitude. You want to make sure they're comfortable. You want to always have conversations that are eye level. And you really need to think about transforming your clinical setting into a warm environment. For patients who seem to remain anxious, even after you tried all these things to calm them down, finally, I think you really need to sit down and just ask them, hey, does being here make you nervous? And a lot of times that simple, admittance, they really, when they identify that, they're a little more apt to open up and talk about it, and from that you can, I think, move on easier. So again, really pay attention. You want to tell them you're going to take good care of them, and obviously ensure that and reinforce that, but sometimes that's just what they want to hear. They want to hear that you're going to take care of them and you have their first and foremost consideration in your mind. So again, open and eye level conversations, look at their medical histories, make sure you're doing blood pressures, and follow those ASA guidelines that are out there on the with the primary care physicians. And again, if you have any questions, get to the primary care physician and find out what guidelines they recommend. But have everyone in your practice learn how to take the blood pressures and learn to ask for these different points of care and treatment, especially again like with the primary care physicians. Let's talk about the sources of pain. There are really 3 sources of potential pain upon administering an injection. Ironically, not associated with the pain is the size or gauge of a needle, as well as the temperature of the anesthetic solution. So most importantly is the speed. So we're going to talk about that a little bit. We're going to talk about also, most like we talked earlier, the pH of these solutions. They tend to be more acidic, so therefore they will have a little bit of a sting to them. So there's ways and techniques in which to reduce that. More importantly, talk about the volume that you give, and talk about the tissue types and a little bit on the needles and the importance of getting good needles. So how do you give a painless injection? Really, really important. The needle stick, how do you get that? How do you remedy? The first thing you need to do is you need to use a topical. Topical anesthetics are really essential to the first step in pain management. And ironically, they're not used. Only about 40% of patients benefit from a topical application prior to the injection. So first things first, you want to look for a good topical that has good clinical effectiveness, and it has viscosity that it's going to stay placed, and it's going to have a pleasing flavor. So here's some of those topical anesthetics that are out in the market today. There's several different ones I can recommend. I like Profound. I like the Progel from Septidine. I've used all of these, as well as the best topical ever. These all work. Regardless of what you're going to use or prefer or what you select, just make sure that you're not putting a massive glob in the tissues, and you're not, you want something that's going to be viscous. You don't want to have something that's going to be runny and their tongue gets in, they swallow it, and then they start to complain and spit, and you just started off on the wrong foot. So completely use something viscous, it stays placed, and you leave it undisturbed. So let's look at what something like this looks like. What you want to do first is you want to dry the tissue. So the picture on the left here, you can see here, we're drying the tissue off with just basically a 2x2. We just retract it with a mirror, and we go ahead and just wipe that with a 2x2. Because what you want to do is remove the saliva and any kind of salivary proteins that are acting as a barrier for that medication. So dry that, and then you want to place the right amount of topicals, not too much. You can see here in the middle picture, we have just a Q-tip in here. We're replacing this, and we're going to leave this undisturbed for 30 to 60 minutes. And we're going to remove that mirror there, and we're going to let that cheek and that lip just fold over on top of that. We're not going to really sit there and talk to the patient too much. We're just going to let them just sit there and just kind of remain quiet, and everything's working good. I mean, you want to carry on a conversation, fine, but I want to let them just kind of relax and just take it easy. The next thing you want to know is after that 30 or 60 seconds, that allows that material, that topical anesthetic, to really penetrate the outer mucosa, and it's going to start to affect the subepithelial nerve fibers, and now you can really go forward and penetrate that tissue with a needle, and you really won't have too much sensation there. The picture on the right just kind of shows you after we've rinsed off that anesthetic. We just kind of lightly suction it and rinse it, and you can, it kind of has a corrugated look to the tissue there. So again, that's just what it looks like, and this is a patient we just did last week. You can see step by step, and again provided a nice injection there, painless injection. Needles are so important, and I want to let you know they are not all identical in their design and also in their manufacturing. And it's so critical to get a sharp needle because they will provide less tissue displacement, and that's going to help reduce a patient's discomfort. It really is important how cleanly the needle inserts into the tissue and doesn't create any drags. And there are qualities of different manufacturing markers, and you can see some brands have barbing, and what happens is when a needle starts to barb, every time it's reused again, and there's multiple uses within that needle, that barbing, the tissue is going to drag. It will not insert easily or cleanly, and it doesn't help displace the tissue as well. And so it's just not as a great painless injection type of component you want to use. So use brands, use needles that are made with excellent quality. They have a microscopic excellent bevel on them. My particular favorite here is the regular triple bevel by Septiject. You can see here there's different studies that have been done and microscopic, again, comparisons, but you really need to think about the scalpel design that they create, how they're marked on the hub, and how there's an indicator as far as how you can inject. So those indicators are important on that. And you also need to think as well about how the hub fits securely on the syringe. I know that some of the knockoff brands that are the cheaper plastics that are on the market today, they make that connection, and it's kind of flimsy. So again, you might lose a little bit of control, and it doesn't feel as secure as it should. So stick with good needle brands, quality brands that can be reused again. They have easier tissue penetration, and that's why I want quality and precision. And I like to personally stick with my Septiject brand type needles, and I do like the Evolution needle too because of the scalpel design. I think it's an excellent needle, especially if you're going to do quadrant dentistry. You might have to do multiple injections, say on the maxillary arch, to achieve that. The next consideration you need to think about is how the flow of the anesthetic relates to an injection. So we talked about the injection rate needs to be slow. And it's interesting because you can see standard needle design here on the left. It has a specific borehole size for that flow, and what we found is by enlarging the borehole on the right example, the flow of the injection can be made easier and of course with less pressure. So there's a lot of studies out there that document this. I'm more than happy to share a lot of what I'm citing here too at the end of the program. I'll share my email address with you, but if you'd like to see the materials list as well, but I'm happy to share the studies and to show you this. But it's really amazing because when you have an easier flow, less pressure, you will perform a painless dental injection, and it really allows you to maximize the flow without pressure, and it helps to really reduce, again, any kind of discomfort for the patient. So again, these are the Septiject XL needles here you can see, and that is my needle of choice as well. It works extremely well, less pressure. And for a woman, I have a size 6 hand. I find that again, certain syringes work easier and better. Obviously petite size syringes work nicely. You can see a Paraject, a couple different types of interligamental syringes here, but again, controlling the anesthetic is really critical as well. And you really don't want to have a syringe that looks like the medieval torture instrument, obviously. So very important to understand control with the flow is going to really help reduce any kind of buildup or fluid under the tissue. And again, if it's done fast, the tissue doesn't have a chance to disperse that, and that's going to cause a little more tissue and pain, deflection, and create more discomfort for the patient. So again, use the right sized syringe in your hand for the right job, for the right procedure, and have that flow and that good control, and always inject slowly. Another strategy I want to talk about is tapping on the shoulder. This is interesting because I've had my assistants do this for a very long time now, and this is really challenging to the gate theory of pain. And the gate theory of pain really asserts that non-painful input closes the gates to painful input, which prevents the pain sensation from traveling to the nervous system, central nervous system, I should say. So really, when you're tapping on the shoulder, it's able to suppress the pain, and from the patient's perception, it's a distractor. So in actuality, the tapping beats out the pain perception for the brain, basically. So try it. It works. While I'm injecting, I'll go ahead and the patient or the assistant will just tap on their shoulder. I'm a right-handed dentist, so my assistants are left, and they'll just tap on that left shoulder. And in years of doing this technique and strategy, I've had 2 patients that just kind of held the hand of the assistant and basically kind of quieted down. Other than that, they just kind of do a nice slow tap, and it works well, and we've had that very, very well received. Let's talk a little bit about palatal injections. And this is one of the most difficult injections to give. No one likes to give them. We know it's going to be it's going to be uncomfortable, and no, patients don't want to get them. I mean, if you go on different websites that talk about dental procedures, they all talk about getting shot in the palate. So it is a necessary evil often, and we need to have strategies to make it as comfortable as possible. So topical anesthetics really don't work as well on the palate because of the thickness of the keratinized tissue. So you got to use a couple tricks here. Always infiltrate first on the buccal or facial aspect of the tooth, and then you can move to the palatal tissue. And a lot of times what I like to do is we'll apply a quick blast of endo ice, and actually we'll put that onto a sterile cotton applicator, and we'll place it just up along the palate and just let that, and just kind of put pressure on that and allow that to stay there, usually for about, again, 20 seconds or so. I'll remove it, and then we'll go ahead and give an injection. And we found that to work very, very, very well. So that's my first way of giving a palatal injection. The second technique I like to do is I'll often take, again, and place my fingernail. I'll push my fingernail a little bit into the tissue, and I'll squeeze out 1 or 2 drops of anesthetic. And what's nice here, bupivacaine works really well here. As I kind of insert the needle, I lift the fingernail's pressure up, and the needle is easily inserted again. So again, there's where you want your needle that can be that doesn't have barbs. It's going to perform well and have a nice surgical precision cuts on it, again, because it's going to be able to insert into the tissue and deflect it nicely. But the key is, as you enter into the palatal tissue, you want to give a little more anesthetic at a time, and again, go very, very slowly, because there's really no room for that anesthetic to move to. So really slow on the anesthetic on the palatal style injections. You can also use a third technique, whereby you're doing an infiltration on the facial or buccal aspect, and then you can go into the papillae later on, and then move that and blanch that, and then move that more lingual as well. This is a little bit trickier, though, I find, because if you're doing any kind of crown and bridge procedures, maybe class 2 composites or something, or resins, you might interfere with actually and rear up a little more oozing. So you got to be careful about that, and really your end point doesn't really achieve as well as what you could have if you just would have approached it and done a straight up palatal injection right off the bat. So again, match the procedure with the style and the technique of the injection. We all have patients that deal with infections, and they're tough. I think for the best results, again, we got to go back to the chemistry. We got to think about the pKa values here, as well as what can really be robust in these situations. You want to have an anesthetic that has obviously a higher liposolubility. Again, articaine really wins in each of these categories, because it's going to have all of those boxes checked that can create and work with an infection much easier and much better, have much better efficacy. So again, articaine is going to be your anesthetic of choice here. Let's talk too about when anesthetic fails. Why? And we've all encountered these situations. It's extremely frustrating. A couple of the tips and tricks I've learned over time, often patients can have situations where, again, they're coming into you and they're not as forthright, but I do believe that you can ask a patient not to smoke for 2 to 3 hours prior to their appointment is a really big benefit, because I think it helps to make sure that their metabolism is slowed down a little bit, etc., and they're kind of they're going to be more on the same page of what you've got to do treatment-wise, etc. They're really sometimes they get more wound up, so that could be something. Find out about how much sleep they've had the night before. Okay, we also have other situations. You could have different accessory nerves. You can have situations whereby you might have where you in the central cord area where you have other nerves that are taking away they're more important than maybe what the central nerve or what you thought you were going to be able to block. So again, anatomy plays an effectiveness on this. Vasoconstrictors play an effectiveness on it. Bottom line is you need anesthetics that are going to be profound, they're going to be liposoluble, and they're going to be able to work in that targeted area that you need to have worked on. So you don't want to have a patient grabbing on you. I know we've had patients where sometimes it just happens and they're very nervous, but again, get control on this, understand what's going on, find out, take their histories, and really make sure that you're approaching this with all the knowledge that you can to make those right choices. It's interesting, oftentimes when you're re-injecting with a different anesthetic, you think, oh, I'll try this one, and you got to think about, again, potential accessory nerves, maybe the buccal or lingual, and that's not working well. You can keep on doing that, but it's really not helping you because, again, you're creating a vasoconstrictive type situation, so you're closing off the target versus opening up. So what I found is if you try infiltrating with articaine, it's going to be better than lidocaine for that reason, and sometimes you might have to even supplement with a interligamental, or you may have to even do an interosseous injection to make sure that you can overcome that. So again, some of those little anatomy referrals or reminders we need to see again. Again, you move down through the list, use a different anesthetic, administer that PDL like I talked about here. Maybe it has to be the interosseous. Go to other tools that are in your kit. That's what you might have to do there. Let's talk a little bit about kids, and I think this is really important. For maxillary extractions, always start off with a topical. And then what you can do is inject a small amount of mepivacaine, which is interesting because it's the least acidic of the anesthetics, like I mentioned earlier. From here, let this take effect for about 2 minutes or so, and then you can follow this up with articaine. And what I found is doing a nice infiltration, and then you can go and inject into the papillae, and then you can go through that papillae over to the palatal side and move upwards and even get into those furcated areas. So that works very nicely. So again, start off with mepivacaine, let that sit for about 2 to 3 minutes, and then follow up with articaine. So kids are tricky sometimes, but I think if you can get them to calm down and you can do the best with them, you're going to win a patient for life. You're going to win their family for life because they really appreciate the care that you can give them and not hurt them, because obviously this makes a big difference. A couple other things for mandibular extractions. You can see here, again, I like to use the Paraject. I like that a lot. A lot of times you can really avoid a block on children. So start off with the topical, load up a little bit of mepivacaine again, and let that just administer that till the tissue actually blanches. And then again, I follow that up with a little articaine infiltration, again, around the papillae, in the furcated areas. You name it all. I tell you, this works very nicely. The reason I like this Paraject syringe, it helps to control really the volume and gives it a lot easier delivery, and it really doesn't look like a shot in their eyes in ways. Not that I'm showing them the needle, but it really makes, I think, a nice delivery, really excellent control, and that clip is going to just deliver a small amount that can be diffused into the tissue, and it really will help make it for an easier delivery. And it's interesting because sometimes I'll tell the kids, I'll say, hey, you know, I'm going to start clicking with my mouth here. Just listen, and really I'm not clicking, I'm really using the clicker, and they hear that, and I make them listen and quiet down. So it's kind of some tricks I've learned over time, and again, you can really win patients over. I'm going to talk a minute about geriatric patients because they're more fragile. We know they have different reduced organ function, kidney function, heart function has changed, their body mass and their water weight. Everything is all changed and it's all altered. So we've got to understand that this anesthetic, once it's been injected and administered, how it's going to relate to their body, and more importantly, how it's going to metabolize and how it's going to be working in tandem with the medications that they're on. So again, think about patients who have any kind of poor kidney function. You're going to have to move over to an articaine type anesthetic because of where and how it's metabolized. So really important. Any kind of patients who have kind of, again, compromised kidney function, use articaine. I want to talk a little bit about a touchy topic, and that's injuries to the nerve. specifically paresthesia. So I know this is no fun to talk about, but the bottom line is, to begin, never inject or continue an injection if a patient cringes or winces. You also need to know that any local anesthetic can lead to persistent paresthesia. So it usually results from the involvement of the lingual nerve and stems really from needle trauma, not the neurotoxicity of the dental anesthetic. So keep that in mind too. Also, if something like this happens in a patient, you know, they'll say it feels like electric shock or something, or they just get that look in their eyes. Well, you need to back out and back off quickly. So if that does happen, you need to make sure you document in their chart. You need to also explain to the patient, and most importantly, you need to really recapture the confidence of that patient that you've got this under control. And you know, you practice long enough, something like this is going to perhaps happen. We don't like to talk about it, but it does, and that's reality. So the key is, don't continue if they cringe, back off, reapply, reapproach, and I think you'll have a win-win situation there. I want to go over a little final some common sense do's and don'ts here, but I think they're really important. And one of those is, you know, I want your dental assistant to, and hygienist too, to think about developing a consistent injection approach with patients every time. So how we're seated, how we raise our hands up and around the patient's face and the eyes. Obviously, we're not showing the patient the needle, but we are very careful in how we hold their cheek and their lip. We allow for good visualization, but we also know we got to get the job done, and how we move and move around that patient is very, very consistent. So work and create that harmony of how you set the stage to give that and administer that anesthetic. That's number one. Another thing you need to think about is your messaging. And frequently you'll hear, like in my office, my practice, hey, Dr. Trost is going to get you nice and numb. Now, what do nice and numb have to do together? They have nothing really, but that message is about assurance and trust. And you've got to create that consistent messaging throughout the office. You need to think about what the patient's hearing, what the patient wants to hear, and how they want to be taken care of. Again, about that experience. A couple things: always make sure you inject in a straight line. You never want to bend a needle. They will break. It will happen, I promise you. So don't go there, don't bend the needles, stay with straight needles and stay in a straight line. Always remember too, smaller gauges are easier to break, and higher gauge needles, excuse me, I'm saying that wrong. Higher gauge needles are easier to break because they are thinner. A 30 gauge is not recommended for a mandibular block, so be careful of that. There's no reports of a 25 gauge breakage for blocks, so that's really, really interesting. Another thing is, do not bury the needle to the hub too as well. Okay? A few final things here I want to talk about strategy-wise. It's proven that increasing the waiting time for a patient will increase their stress. And this is really critical, because I think you need to look at a 10-minute increment of time and create a time policy. So if you have a patient who is waiting, their stress level is going to be going up. So you've got to have some kind of policy in which you need to move that patient, and more importantly, you need to learn how to communicate to that patient for their wait. No one likes to wait, and I know that we have crazy schedules sometimes. A lot of things are out of our control. But you've got to realize, in their eyes, it's all about them. So have some kind of strategy in which you know every time when a patient's coming in how long they're waiting, and move them. I don't care if you got to move them in a consult room, or you just have to move them in a chair to have them sit to a different place, but you need to move them, because that will reduce their stress. That will have them have a better experience with their dental treatment. I promise you. Very, very important. Another thing, which is, again, common sense here, you've got to create a welcoming, less clinical environment. Patients need to relax, and you need to really appeal to their senses. Visual-wise, you want to have nature or landscape type pictures hanging. You want to use aromatherapy. I know this sounds maybe crazy, but again, this is about their experience. It's not their treatment. You've got to develop empathy. You've got to listen. Have everyone on your team be paying attention. Really make sure your messaging is consistent, and all your team members are really promoting a really nice experience. And I think patients truly appreciate that and that approach. I think that's a really win-win, and it will bring patients back in your door and they want to seek your care again. So again, think about this as an experience for them, just not the treatment that we think. We get focused on treatment because it's a tough job sometimes, but more importantly, it's about their experience. All right, I'm ready for some questions here, and I've got a lot of good ones here, so I'm going to try to get to as many as I can here. All right, first off here, does warming anesthetic help? All right, so the literature shows right now, and many manufacturers will also tell you not to warm anesthetic because it actually can break down the anesthetic solution and its efficacy. So you might be warming the solution thinking it's helping the patient, but effectively it's not really helping. So we try to keep things at room temperature. And obviously, when you're in colder weather, you might think warming it up to body temperature doesn't help, but that can really throw things. So keep things into room temperature. That's the best to offer there. Another good question. What is the cost of Oraverse? Oraverse is right around, I believe, $10 for a carpule. Again, we do charge an additional fee for this in our practice. I believe we charge $17, and we don't have patients really debunk at that at all. They welcome that because they see this as a really great service for them, an adjunct, and it really works, I think, very well as far as referrals go. And once they've had it, they want it again. They'll come back and ask again for that product. Is Oraverse safe for all patients? Yes. There's no contraindications for Oraverse. I want to underscore that as well too. Good questions here. Another good question. How soon can you re-inject with Articaine? 30 minutes is the half-life. We talked earlier about that. And so within 30 minutes, you're safe to re-inject with Articaine. Really, really good questions here. Good question here on Oraverse. Are you using a 1-to-1 solution ratio for children? Again, go on the manufacturer's instructions, but you can see here for adults, there's cutoffs over the age of 12, and then weight, according to their weight, you can drop down even to like 1/4 of a cartridge. And again, it's going to be a 1-to-1 ratio. So whatever you're getting in, compared to what their weight is, that's where your efficacy is going to be in your management and selection of how much you're going to be dosing you're going to be giving. So you need to really probably ask as well before you even consider this, what is the weight of that child? And this is a really, again, a great presentation for your parents. They really appreciate this too because you practice long enough, kids are they're gonna chew up their lip or their tongue, and it's really really tricky when that happens. And you can message as much as you can to them, but the inevitability it will happen. So you got to be careful and cautious with that. Another good question here. What anesthetics are appropriate for pregnant patients? Good question. First of all, I would talk to their OBGYN and get approval for any kind of work that needs to be done. But I think what you need to look at, Prilocaine plain is a very good choice that has no epinephrine. So that is a really good, again, anesthetic to use with a patient who is pregnant. So Prilocaine plain, it has no epinephrine, has no vasoconstrictor in it, and is partnered with that as well. Okay, another good question. Do I use Articaine for inferior alveolar nerve blocks? Yes, I do. I can also tell you that for first molars, by and large, on the mandibular arch, I will use an infiltration process. I'll do, I use the Paraject often. I use the PDL as well, syringe. So I've got a couple different tips and tricks there that I use for that, and patients get very nicely anesthetized for that, and it's comfortable for them as well too. Another good question here. What is the best anesthetic to use when you're dealing with hot teeth or with an infection? I'm going to go back to Articaine. I think Articaine, again, is the correct choice because of the liposolubility and the way that it can go into the target and really effectively create the proper amount of anesthetic and really it makes good sense because it has a broad scope because of liposolubility and its onset and its duration. I think it works really, really nicely there for that. I do want to emphasize here, what are any kind of contraindications for articaine? Again, I want to reemphasize any kind of patient who has a sulfite or bisulfide allergy, you got to be careful of any kind of vasoconstrictor. So anything that's partnered with a vasoconstrictor is contraindicated. So there's several, obviously, anesthesias that fall into that. I know that articaine could be one of those. Mepivacaine, like I mentioned earlier as well. So be careful with those and partner with those. You're going to have to choose a different methodology there. I want to thank everyone for joining the program. If you would like to contact me to get a list or to get any of the data that I've talked about, you can feel free to email me at trost@htc.net. Have a good rest of your day, and thank you so much for joining, and remember to follow the cue at the end of this program right now. Thank you.